Hello, I'm Mukta Krane, one of the colorectal surgeons at the University of Washington, and today I will be speaking on sexual health and inflammatory bowel disease. Treatment outcomes are usually measured in terms of eradication of disease and/or symptoms depending on the pathology. For instance, for colorectal cancer, we'll talk about local recurrence rates and disease and overall survival. With inflammatory bowel disease, we'll look at symptomatic relief, dependence on immunosuppressant medications, and disease recurrence. And for postoperative complications, we often measure those in terms of rates of anastomotic leak, surgical site infections, and mortality. However, as we have improved with both medical and surgical management and the emergence of patient-reported outcomes, we've seen a gradual shift and a greater degree of interest being paid to functional outcomes and overall quality of life. And I think that we can all agree that the ultimate goal of surgical and medical therapy should be a focus on eradicating disease while preserving or improving patient quality of life. Quality of life is a non-specific term, and it actually incorporates a number of factors or domains, as you can see in this diagram, which is not at all exhaustive. While each one of these domains is an important topic for discussion and perhaps a talk at a future meeting, today I will predominantly be focusing on sexual health. There are a number of measurements of sexual health. They're both dimensions of sexual health, which I think of as factors that influence intimacy or sexuality, including physical, emotional, social, mental, spiritual, relationship status, and fear. And then there are the domains of sexual health, and these are the actual factors of intercourse or sexual intimacy, and these include desire, arousal, orgasm, sexual satisfaction, and erection, lubrication, and pain. One of the major problems with some of the studies that were done earlier looking at sexual function is that they didn't use validated surveys. And so they were plagued with bias based on how the question was asked. And it was very difficult to compare data between studies. In the last 20 years, we've seen the emergence of a number of validated questionnaires on sexual function. And in the last few years, we've seen some that are IBD specific, namely the IBD specific female and male sexual dysfunction scale. These are the type of questions that you will see in those surveys. So they generally look at sexual function and intimacy over the last year and look at how Crohn's disease or ulcerative colitis may be contributing to distress with sexual life, difficulty in starting a relationship, effect on sexual intercourse and intimacy, how symptoms or pain may affect sexual function, and overall how negatively or positively UC or Crohn's disease may affect sexual health. Now, why is this an important issue to discuss? While understudied, there has been data to suggest that this is a very important topic for patients with inflammatory bowel disease. In fact, in a study of about 5,000 IBD patients, 40% of them reported that the disease prevented them from pursuing intimate relationships. Almost 70% of patients stated that IBD had a negative impact on body image, particularly those that underwent surgery. 45 to 60% of female patients with inflammatory bowel disease and 15 to 25% of males with inflammatory bowel disease reported sexual dysfunction, compared to 30% of women and 5% of men in the general population. While sexual activity rates in IBD patients is similar to healthy individuals, sexual satisfaction scores are lower. And infertility and voluntary childlessness is increased in the IBD population. Now, before we look at some examples of the data, I want to first talk about some of the myths and barriers of sexual health and inflammatory bowel disease. The first is that IBD does not affect sexual health. In fact, we know that up to 50% of patients with IBD experience some degree of sexual dysfunction. The second myth is that women are not concerned about their sexual function. This is often a reason why traditionally studies predominantly looked at male patients both for IBD and cancer compared to female patients. And this myth is particularly problematic when looking at women that are over childbearing age. The data, in fact, shows that over 60% of women desire information on the effect of IBD on sexuality and intimacy at the time of diagnosis. Another myth are there are no treatment options. We'll discuss this a little bit more later on in the talk. One of the major barriers is the personal nature of human sexuality. So this is still often considered a taboo topic, both for patients and providers. As a colorectal surgeon, I always find that interesting because I'm often talking to patients in great detail about their bowel function. And yet many surgeons will say that they still, while they can talk about bowel function, they find it difficult to talk about sexual function. There is a failure of healthcare providers to discuss sexual health at the time of an initial diagnosis and throughout the course of the disease. In fact, there was a survey of healthcare providers that found that 93% of them felt that sexual health was an important topic to discuss with patients with inflammatory bowel disease. However, only 16% of them stated that they did. The major reason that they had for not talking about sexual function is that they did not have an awareness of what treatment modalities or management was available in the event that a patient stated that they had sexual dysfunction. They also reported that they felt uncomfortable, or they perceived that patients would feel uncomfortable discussing sexual function. And some stated that they did not feel that they had enough time in the visit. I think ultimately there is a lack of training in medical school and residency on how to discuss sexual health. And as a result, healthcare providers don't have the confidence needed to talk to patients. Studies that have looked at sexual health in patients with inflammatory bowel disease have attributed sexual dysfunction to a number of factors. Those include anxiety and depression, and in fact, in most of the studies, those are the most common causes of sexual dysfunction. An impaired overall quality of life due to symptoms, fatigue, and in some circumstances, use of steroids. Interestingly, immunosuppressants and biological therapies were not associated with increased sexual dysfunction. Disease activity is a little bit more controversial, with some studies finding that it does not affect sexual function, while others, such as the one I'll show next, find that symptoms of inflammatory bowel disease are directly correlated with sexual dysfunction. I think one of the difficulties here is that it can be difficult to parse out the actual symptoms or inflammation and the anatomic effect that it may have versus how those symptoms often cause or related to anxiety, depression, and a decreased overall quality of life, which can have a significant impact on sexual health. I wanted to highlight one study which was recently done because it not only used a validated survey, but it was one of the IBD specific surveys. So this was a study of almost 300 women with inflammatory bowel disease. And what they found was that the majority of patients were sexually active and had sex with men. They found that 73% of women stated that they were comfortable talking to their doctor about sexual health. 2/3 of them preferred a female provider, but 1/3 of them had no preference. A large number reported that fear of passing gas, stool, or urine during sexual intercourse impacted their sexual function. They also stated that symptoms, and particularly pain during intercourse, were one of the #1 reasons why they did not participate in sexual activity. They found that IBD prevented the start of a sexual relationship in about 23% of women, and over 2/3 found that IBD caused distress in their sexual relationships. I would be remiss if I didn't talk about the impact of surgery as a colorectal surgeon. So interestingly, surgery can have positive and negative effects on sexual function in both men and women with inflammatory bowel disease. In terms of positive outcomes, surgery may result in the remission of disease with resolution of symptoms and an overall improved quality of life. It can also decrease disease activity and possibly the need for medical management. In terms of negative effects, pelvic surgery, particularly rectal dissection, can cause injury to the nerves that are responsible for sexual function. In addition, local fibrosis and scarring may lead to pain with intercourse. Depending on how much intestine is resected or removed, patients may experience increases in incontinence and leakage, and the fear of incontinence and leakage during intercourse may prevent them. In addition, surgery can negatively impact body image, particularly if patients have setons or stomas. The procedure that probably has the greatest impact on sexual function is a total proctocolectomy, and that is when we remove the entire colon and rectum. Patients either will have a permanent end ileostomy, or GI continuity can be restored with the creation of an ileal pouch. And what that is we take small intestine and we essentially create a neorectum. I have this picture up not because I expect everybody to memorize the nervous system and be quizzed after the talk, but to show the female pelvis, which is right here, and the male pelvis, and to show this interconnected network of multiple areas of the nervous system. So when we're operating in this area, there is a risk of injury to these nerves, but sometimes they just become strained with the dissection itself or fibrosis and scarring that happens after surgery. There have been a number of studies that have looked at the effects of surgery, particularly proctocolectomy, on sexual function. This was a review of some of the earlier studies, and it found that the majority of patients reported that they had decreased sexual function and increased pain with intercourse after surgery. One of the flaws of most of the early studies is that they don't use validated surveys. The other is that they didn't collect baseline data. And so they talked to patients after surgery and determined what their sexual function was, but they couldn't compare it to their function prior to surgery. There was one recent study that looked at this in 66 patients who underwent proctocolectomy. They used validated surveys and they collected baseline and post-operative data about 6 months after surgery. As you can see here in the male-specific survey, sexual function in almost all domains was improved after surgery compared to baseline. In female patients, it stayed pretty stable to baseline with the exception of sexual desire, which was improved in patients after surgery. This was corroborated using another survey instrument in which, once again, there was a significant improvement in almost all of the domains of sexual function in men after surgery and stability with a trend toward improvement in women. When they looked at patients specifically as to whether they had creation of a pouch or an endoleostomy, they did not see a significant difference. In patients undergoing endoleostomy versus ileal pouch, there were no significant differences. And again, both patient populations had improvement or stability in sexual function after surgery. The authors of this study felt that while surgery did contribute to sexual dysfunction during the dissection and manipulation of the pelvic structures, and possibly with fibrosis and scarring after surgery, they felt that this was outweighed by resolution of symptoms and improved overall quality of life. And what indicates that to the greatest amount is the greatest improvement in sexual function was seen in the domain of sexual desire. So what can we do for patients when they experience sexual dysfunction? The first is that we have to have an increased understanding of the impact of inflammatory bowel disease on sexual health and improve dialogue between patients and healthcare providers. We need to screen patients for impaired function using validated surveys, both before and after treatment. We need to discuss modifications in management depending on disease activity and overall quality of life. Referral to psychosocial experts or therapists, particularly if patients are experiencing anxiety or depression. And lastly, a collaboration between providers, including urologists and gynecologists, particularly after patients have had surgery. We know that some of the consequences or side effects of surgery can be improved with physical therapy and/or medical management. As you can see in this diagram, sexual health is the interplay of a number of factors and a number of different providers. I'm going to slightly switch gears now and talk about inflammatory bowel disease and fertility. These often are interrelated, although I do want to be careful to say that they're distinct entities, and sexual health is important, not just in how it relates to fertility. Approximately 50% of patients are under the age of 35 at the time of diagnosis of inflammatory bowel disease, and about 25% of them conceive for the first time after diagnosis. Infertility is defined as the inability to conceive within 1 year of unprotected sexual intercourse. Earlier studies, particularly this study of 300 women with Crohn's disease, indicated that patients with Crohn's disease had higher rates of infertility. Some studies found up to 60% increased rates of infertility in women with Crohn's disease. However, a lot of these early studies did not take into account the desire to have children. And as we can tell from the Scottish study, which also looked at female patients with Crohn's disease, involuntary infertility was actually equal between patients with Crohn's disease and those of the general population, while voluntary childlessness, or the desire to not have children, was increased about 36% in patients with Crohn's disease versus 7% in the general population. This was further supported with a large study of almost 10,000 patients recently out of the United Kingdom. And what they found was that there were decreased rates of fertility in patients with both Crohn's disease and ulcerative colitis, but not in involuntary infertility. Those were actually equal between patients with inflammatory bowel disease and the general population. Where they saw a substantial difference was the number of patients with inflammatory bowel disease who chose not to have children. Patients with inflammatory bowel disease will experience the same issues with infertility as the general population. So those include advanced age, smoking, and other medical conditions. However, they will also have a unique set of factors that will affect fertility. Those include apprehension about fertility or concerns for adverse pregnancy outcomes. And often we hear of patients that are pregnant or trying to conceive that actually stop the medications without discussion with their healthcare provider due to a perceived concern that there will be increased complications. I do want to underscore that if patients are thinking about conceiving a child or pregnant, that they should definitely discuss these concerns with their healthcare provider, and certainly if they're thinking about stopping their medication. There's also a concern of risk of IBD in the offspring. And we do know that there is a genetic component to inflammatory bowel disease, but I don't think that we can quantify what that risk is. In terms of involuntary childlessness or infertility, that is often due to sexual dysfunction, surgery, and in some cases, disease activity. I'm putting this slide up here, but I will disclose or have a disclaimer that I am not a gastroenterologist. I'm a colorectal surgeon, so I don't normally prescribe these medications and don't know all of the adverse effects. I am showing a slide from a review that was done by a number of experts that show that while not all of these medications have been tested in humans, with the exception of sulfasalazine that can cause a decrease in sperm production, that there is no significant effect on fertility. The only medication that is absolutely contraindicated is methotrexate, which has been known to cause fetal abnormalities. In terms of surgeries, there is an increased risk of infertility with pelvic dissection. So when I've talked about the previous studies, which compare the general population to those with inflammatory bowel disease, many of them did exclude patients who had undergone intestinal surgery. And the reason is because there is data to show that on average, the risk of infertility is about 3 times higher for patients undergoing proctocolectomy or removal of the rectum. There is, however, recent evidence to suggest that there may be benefits to a minimally invasive approach, which is laparoscopic or robotic. This was a study that compared infertility rates in patients with inflammatory bowel disease undergoing a restorative proctocolectomy with a pouch this are patients who underwent the procedure laparoscopically, and in this patient population, about 70% were able to conceive versus those in the open group, which was less than 40%. However, when they accounted for patients that underwent in vitro fertilization or other fertility treatments, those lines actually, the space between them significantly narrowed. And in fact, this data demonstrated that while the rates for open were still lower for conception than those patients that underwent laparoscopic procedures, that it actually was not statistically significant. What this data would indicate is that the surgery does not affect the ovaries itself or egg production, but due to either handling of the tissue, particularly the fallopian tubes, or fibrosis and scarring, can impair the function of the fallopian tubes. In conclusion, inflammatory bowel disease has a multifactorial impact on sexual health. Sexual health is often not addressed by healthcare providers. Management of sexual dysfunction in the setting of inflammatory bowel disease needs to be a multidisciplinary approach. And rates of involuntary fertility are not increased in the non-surgical IBD patients. Thank you for your time and attention, and I'm happy to take any questions.